none other than Dr. DENIS XAVIER. He has got this knack to make complex topics so simple. Unfortunately, I was not there during the last session. I'm just parachuting today right into this session, so it would be a bit difficult for me, but I look forward to learn from Dr. DENIS today. Over to you, Dr. DENIS.
Right. Thank you, Dr. Arvind. I'll just share my slides. Right. So. All right. So this is our third session on statistics. Um, we covered the basics of statistics and what p-values are, what confidence intervals are, and the different types of data before that, how to summarize data, all of that we did. Then last time we did the most common parametric test, which is the different types of t-tests, the unpaired or the simple t-test, and then the paired t-test. Then we did ANOVA and COVA, then we did MANOVA, etc. And then today we'll cover non-parametric tests. So in non-parametric tests, we have the following. We'll do the chi-square tests. So always note it's not just a chi-square test, it's plural, it's chi-square tests. So within that, we have Yates correction, we have the Fisher's exact test and the McNemar's test. I'm sure you have seen all of this in journal articles in the statistics section. And today we'll get a little more clarity. As Dr. Arvind mentioned in his opening remarks, what we will try and what I will try my best to do is to keep this as simple as possible. And the fourth type of chi-square test is the MH test or the Mantel-Hansels test. Then we'll do the Kruskal-Wallis test, the Mann-Whitney-U test as well. So these are the tests that we will do for today. Okay, let's straight away dive into an example. And for all of you clinicians, I'll take clinical examples. And this is maybe when you were doing general medicine many years ago, or general surgery, you'd come across these kind of situations and you want to test it and see. And I will use small numbers and I'll also show you the formula. And as always, I keep telling you, you don't have to remember any formula, but at least to know what is what. Okay, right. So group of clinicians, maybe over coffee, they were discussing and said, some of my patients, I put them on steroids and then they're developing ulcer. Oh, is it? Some of the clinicians said, no, that's not so common. Other one says, yeah, I'm noticing it. Or maybe you had a high dose. No, same dose. So they were discussing over coffee and said, oh, okay, now another person, maybe he attended one of these courses, he or she, and then said, okay, let's do some research. Okay, I know about a little bit of research designs. Let's do this. Okay, so what is the research question now? Among patients visiting a particular hospital, what is the relationship between steroid use and peptic ulcer? Okay, note that we are not asking whether steroid is causing peptic ulcer. What is the relationship? And in one of our study design lectures, we looked at the difference between association and causation. So I'll remind you of that. So what is the relationship? I used a very generic term, relationship. Okay, simple study, 120 patients. In fact, these are sample sizes that undergraduate students do, postgraduate students do. Not a very big study, simple study, 120 patients. Okay, now listen to this scenario now. Okay, out of 70 patients who took steroids, 76% developed peptic ulcer. 70 who took steroids, 76%, that is 53 out of 70, developed peptic ulcer. Now, life is not so simple. Okay, look at the next scenario. Out of 50 patients who were not taking steroids, 26% had peptic ulcers or, had anyway peptic ulcers. So this is the 70 plus 50 patients. Okay, so we totally have 53 plus 13 patients. Okay, so that is 66 patients out of 120 patients totally had steroids. Okay, so this is the scenario, and this we will see if nobody, I mean, or people who did not take steroids, if none of them had peptic ulcer, is a different situation. But this is clinical medicine, and this is what we see in our hospitals. Now, is this so clearly 76% and 26%, 3 times difference? Is this statistically significant? What is the meaning of this word statistically significant once again? That means, is this relationship real or is it just due to chance? Real means if you do a similar study in another population, we'll get a similar result. Or is it just out of some chance we got this result? That is the meaning of statistically significant. All right, then we do the chi-square test. Okay, it's a test of significance for association. Okay, it's more than 125 years old. Carl Pearson, you may also know the Pearson's correlation coefficient. We'll do that a little later in the day. It's a non-parametric test. So if data are not normally distributed, right, we can do this test easily. Okay, it does not make any assumptions. Remember, for t-test, we need to fulfill several assumptions, normally distributed, etc., etc. Okay, and this association follows a chi-square distribution. We'll look at this later. I'll actually show you today a table. It's called the chi-square distribution table, just for us to get a feel. And in the old days, when I did my statistics for the first time in the 1990s, we were still using this, distribution table books, and we were doing it. Okay. Right. So what are the chi-square test for? To analyze the difference between a set of observed and expected frequencies. So let's understand what is observed and what is expected. Okay, requirements for chi-square test. Data must be from a random sample. They are nominal or categoric data. So you will not have any decimals here. Okay, and in the form of a frequency or count data. Okay, now for a chi-square test, the frequency should be more than 5 in any particular group. Okay, here are the steps for calculating the chi-square table. Make the contingency table. What is the meaning of the word contingency? Contingent to, that means if you take a 2 by 2 table, right, after you put the first number, the second number is dependent somewhat or is related to the first number. And then the next number is related somewhat to the other two numbers. And the third number is related. Related means contingent upon. It depends on that to some extent. That's the meaning of the word contingency table. Okay, so where are we now? Our outcome is peptic ulcer. Our exposure is steroid use. Okay, so there are people who took steroids and got peptic ulcer here. People who took steroids did not get peptic ulcer. Remember, people who did not take steroids also got peptic ulcer, and people who did not take steroids also did not get peptic ulcer. That is what it is. Remember those numbers. So let us look at this again. Oh, sorry, I should not have put those lines there. Give me a few seconds. I'll take off those red lines. Sorry, just few seconds. Okay, it's gone. I'll share it back again. All right, so there we go. Okay, so contingency table, and okay, this is the 2 by 2 table. Just mentioned to you. Oops. Okay, right. So now in this table, 53 patients who took steroids got peptic ulcer. 17 patients who took steroids did not get peptic ulcer. 13 patients who did not take steroids got peptic ulcer, and 37 no steroid, no peptic ulcer. Okay, so we total this up: 70 plus 50, 120. And this way, 66 plus 54, also 120. All right. So these are the observed values, the values that we are seeing. All right. Now, how do we calculate the chi-square test? Later on, you only need to know how to plug in the numbers onto any software, and all of their manuals are very simple and clear. But briefly, to know what is happening behind the scenes, it's nice to know. So in other words, all of you surgeons will not go straight away and cut. You will first know anatomy, right? You've done your anatomy, then you've done your basic surgery, and then you've done your advanced surgery. And even before you cut, you want ultrasound, you want, the size of the tumor, the positioning of the tumor, the relationship between the tumor and the large blood vessels there, all of that, before. So just to get a background, idea of this is why I'm explaining this to you. Okay, so first is we need to determine what is called the expected values for each cell. That's a principle for chi-square test. Expected value for each cell is very simple. Row of the total, total of the row. That's what I meant. Total of the row into total of the given of the column divided by the total sample size. So let's suppose. Uh, can the admin just mute everyone else, please? Okay, right. So remember this. These are the numbers we saw. This is the 120. Okay. So row of the total. Okay, total of the row. Again, I'm making that mistake into total of the column. Okay. So for cell A, this is cell A, right? What is the total for the row? 70. And what is the total for the column? 66. And what is the overall total? Is 120. So this is what goes for A. This is for cell A. So we get this number. It is 38.5. So A now, observed value is 53. Expected value is 38.5. Okay, right. Now we calculate the expected values for all the cells, right? So remember, this is the old table, and 38.5 is what we did in the previous slide. Similarly, we calculated for this and this and this. Now the formula for a chi-square test is quite simple. Now this is the expected value. These were the observed values. This is the expected values. Now the chi-square is quite simple. It's the sum. This is the summation. Okay, this is the sum of observed minus expected whole squared minus divided by the expected. That's all. Don't worry about trying to remember this. So here we go. So for this is for A, this is for B, this is for C, and this is for D. This is totaling up everything, right? And this is the expected value for each of those cells, A, B, C, and D. We total up all that, and we get the chi-squared number as 29.1. And this number you write in your journal article. You have to show this number, okay, your chi-squared, either in your table or in your text. So how did the number come? This is how it came. Okay, so the calculated chi-square is 29.1. The question is this statistically significant? Okay, so for that, we need to know the degrees of freedom in which we are operating for this particular test. I told you earlier also, what is the degree of freedom? Degrees of freedom is the total number of calculations that we are making minus the total minus the numbers that we have. I'll show that to you. Okay, degrees of freedom for the chi-square test is number of rows minus 1 into number of columns into 1. How many rows we have? 2 rows and 2 columns. Can we have more than 2 rows? Yes, sometimes we have. Now this is just a simple 2 by 2 table. You can have more than 2 rows, you can have more than 2 columns as well. So for this, now it is simple. 2 rows, 2 minus 1 is 1. Again, 2 minus 1 is 1. So degree of freedom is 1 into 1 is 1. Simple. So that's the degree of freedom. We need the degree of freedom to calculate our significance. So the calculated critical chi-square value we need to see from, and I'll show it to you in the next slide. As I told you, I'll show you that table itself, is 3.841. How does this 3.841 come? I'll show it to you just now. Okay. So what is our degree of freedom? Is 1, right? So 1, and we are testing at a p-value of 0.05. So this is our 3.841. Got it? So this is what 3.481 is the critical chi-square value. Critical chi-square value. Okay, at that value, now what is our real chi-square or not? Sorry, the calculated chi-square value, and this is the calculated critical chi-square value at level of significance of 0.05. Okay, so we got this 3.841. Now we need to draw a conclusion. So if the calculated chi-square value is more than the critical value, we reject the null hypothesis. That means it is statistically significant. Now, what is it that we have? In the example, the calculated chi-square is 29.1 and the critical chi-square is 3.8. It is way above. 29 is way above 3.8. So since it is thing, we reject the null hypothesis. That means we say there is an association between steroid use and the development of peptic ulcers. And it is quite a strong association. Now, how to write this in the journal articles? This is how we write. Steroid use was significantly associated with the development of peptic ulcer. Then we need to mention degrees of freedom equals 1. The chi-square value is 29.1 and p less than 0.05. Now, these days, softwares will give you the actual p value. It will give you 0.00321, something like that. You will get the actual value as well. The software will give you. Okay, so that is how we do the chi-square test and we report it. Now, what is AIDS correction? Now, when the expected value for any particular cell is less than 5, it is, if it is less than 5, any particular cell. So, when you're doing it manually, you will get all of this, actual value and the calculated value. And then you say, oh, one particular cell out of the 4, one particular cell is less than 5. I cannot use the chi-square test. I need to use the AIDS correction. Right. So now the software will give you, it'll tell you one or more cells, expected value is less than 5. Therefore, use the, or recommend to use the AIDS correction, the p value that you get from the AIDS correction. AIDS correction, very simple. You remember this formula, right? This formula. Okay. Very simple. You just have to minus it from 0.5. That's all. It's a small difference. Okay, minus it from 0.5. That is the only difference in the formula. Okay, so the sample size. And you will get your calculated chi-square value. You check it from the critical value, degrees of freedom. All of that doesn't change. The formula, there is a small change. However, what experts caution us is if the sample size is very low, results may not be conclusive or it will be kind of misleading. Okay. Now, there's an alternate when the sample size is very low and more than one, you may get 0.05. Then not just AIDS correction, you need to do the Fisher's exact test. The software will again tell you. Okay. Since sample size is low, it will tell you, it will give you everything. Now, why do you need to do this? See, some of you may tell, I can do this. I mean, software there. Why do I need to learn all this? You need to know the principles behind this so that you know which one to apply, chi-square or the AIDS correction or the Fisher's exact test. And you will see this often in your journal articles. So pull out in any one journal issue, if you take out, if you have a hard copy or if you just search there, at least in any issue, at least half a dozen times, you will see AIDS correction and Fisher's exact or chi-square test, one of the two. So what are the Fisher's exact test? For very small sample sizes, sometimes we do that, let's say rare tumors, and you will get, in 2 years, you will get 32 cases, right? And then you may do a randomized trial, 16 here, 16 there, and you do a chi-square test, you'll get very small values, okay? So Fisher's exact is also unreliable for very small. Okay, I'll skip that part. And just to let you know, and I don't want to trouble you with factorial mathematics, but all we need to know is a function is applied. Okay, function is applied and the formula changes a little bit to get the exact p-value. Okay, I'll skip some of these details. And then, so we'll go back to this formula here. And how this formula changes, where we use factorial mathematics, is a plus b factorial, c plus b factorial, all of this. So, and the total sum, and you multiply all of this and take the factorial. That's all. Okay. So that is the how we calculate and get the Fisher's exact test. So just for you to be aware of that. Okay. Now let's go to another scenario. Okay. Now this is about 314 individuals who run more than 25 kilometers a week. So these are serious runners. Okay. And then some of them complaining of knee pain and issues. So people said, okay, let's try glycosaminoglycans for a month. Okay, and there are 4 possible scenarios in this. Okay, so there are people who had knee pain before they started treatment and they continue to have the knee pain after treatment, no change. The people who had knee pain before treatment, after 1 month, no knee pain, they were thrilled. Now look at this scenario, third scenario. This is how biology is. It is not physics. Okay, biology is all over the place to mess us up. These people had no knee pain before treatment, and after treatment, they developed knee pain. Now, is it because of the treatment? Or is it because of something else, or because of their running, or whatever else? And the last group is a happy group, no pain before, no pain after. Okay, so let's look at some of these numbers. Okay, 101 people had knee pain before, knee pain after, no difference of treatment. There's 121 people, okay, had knee pain before treatment, but the knee pain disappeared after treatment. Fantastic. Okay, and look at this group. 59 people had no knee pain before, and then they developed knee pain afterwards. So these are the totals now. So there were 222 people who had knee pain before treatment, and 92 people who had no knee pain before treatment, and people who have knee pain now and no knee pain now. Okay, so total sample size is 314. All right. For this, we do the McNemar's test. McNemar's test is a test of proportion. It is for paired or matched nominal data. In the paired t-test, it was continuous data. Right? It could be blood pressure, it could be BMI or weight or HbA1c, blood sugar, whatever else. Okay. So, but here it is nominal data. See, in nominal data, I'll just go back. You won't have 101.4 people, but you will have HbA1c of 6.8. And you'll have a decimal pointer. Here, there are no decimal points with, these are all whole people. Okay, so that's why we do the McNemar's test on matched nominal data, paired or matched nominal data. So as I told you, it is an analog of the paired t-test. Okay, so when we got independence, Quinn McNemar was busy doing and publishing the McNemar's test. And here also, this follows a chi-square distribution. The same table that we saw that time applies here as well. So, a number of people, once again, had pain before and after, so on and so forth. Okay. So, this is how we write the chi-square McNemar's test. Capital M. We have the Mantel-Hansel's test, where there we write chi-square MN. Okay. So, here, so the formula for this is B minus C whole square, B plus C whole square. Okay. So we seem to be using only B and C. Alright, why are you ignoring A and D? A and D is very upset now. They feel left out. Okay. So we're using. Why is that? Let's look at it. Okay. Only B and C cells are considered because they are discordant cells. What is the meaning of discordant? Before and after situation changed. The situation that was there before has changed after treatment. Okay. All right. So C number of people had no pain before treatment, but after treatment, they got pain. Okay. And B number of people before treatment, they had pain. After treatment, the pain disappeared. These are called discordant cells. So the opposite of that is cordant cells. A and D are cordant cells. No change. Before and after, no change. I am not so interested in this. I am interested, or statisticians are interested in this discordant cells. Okay, right. So the same critical value we apply here as well. Okay, so let's apply these numbers. So just to remind you of these numbers, chi-squared M equals B minus C whole squared, B plus C. We compute this. So do you see this 121 here, 121 here, and 59 here, and 121 plus 59, and this is squared. So this is chi-squared McNemar's test. We get 21.3, and you remember that is 3.14. Okay, so how do we write this? It's important for us to interpret it. In those running 25 kilometers a week, glycosaminoglycans significantly reduce knee pain over 1 month. Reduce knee pain over 1 month. So this is how we write it. Chi-square M, actually the M should come here, it is slipped off in my slide. Okay, 21.36 degrees of freedom is 1. The same thing, 2 by 2 table, it's 1. And P less than 0.05. That means this is statistically significant. Okay, let's go to the next one, the Mantel-Hansel chi-square test. Let's look at, this is looking at the chance of an event occurring under independent groups in stratified samples. What is the meaning of stratified samples? The best way to understand this is to look at an example. Okay, and so it is 2 into 2 tables. The previous 2 examples we took were 2 by 2 tables into K tables. K is the number of conditions or the strata that we are looking into. Now, this is an analog of the two-way ANOVA. Remember, we had 3 or more groups there. This is the two-way ANOVA used, and generally Mantel-Hansel's test, chi-square test, is used for sample size more than 30. Okay, let's take that. Let's take an example now. There's a clinical trial for migraine done. Okay, now what is the research question? And in migraine affects men and women differently. Okay, so I'm doing a new drug versus a placebo, and I want to see if there is a difference among the two genders between male and female. So look at the scenario now. Okay, so and you will also see this in journal articles. This is the effect of a new drug after adjusting for age or gender or severity of disease or ethnicity. Remember, we'll get this adjusted for this. This is the meaning. That means that strata is taken care of. Okay, so look at the scenario now. So we have treatment, response is better or same, and then we have gender here as well. So males, active, placebo, better, same, better. Okay, and we have among females here. Now, can one of you tell us what is the total sample size in this trial? Anyone?
106.
Right, excellent, sir. Okay, so the total sample size is 106. Very simple. Add up this and this. Are the number of males and females similar? Somewhat similar here. It need not be. Okay, sometimes it won't be, but here it happens to be somewhat similar, 54 and 52. Okay, right. So this is the hypothesis that, and we'll skip that. Okay, this is the formula for the chi-square Mantel-Hansel. I'm not sure you want me to sit and explain to you this. Don't worry. Okay, don't worry. Okay, so we do that. But the same thing, observed minus expected, comes here again. The principle remains the same. This is the formula. Don't bother about that. Okay, I didn't even bother explaining it to you. So we compute all of this. Remember, we're talking of chi-square Mantel-Hansel. Okay, we get this. So numerator is 45 and denominator is 6.3. And then we get the chi-square Mantel-Hansel 7.21. And that is still greater than 3.14, remember. Okay, so again, degrees of freedom 1, alpha at 0.05, okay, is 3.842 here. Okay, so your Mantel-Hansel's chi-square is greater than the critical chi-square. So we reject the null hypothesis. That means what? There is a difference. But we are doing something different here, isn't it? What are we trying to do?
Planes where will the planes park? On the runway itself or garage?
Okay, we have some new participant joining us.
Why?
Dr. Chandramohan can mute everybody else except Dr. Dennis.
The admin person or whoever is there, they should have the list of all the participants on the side and immediately mute those people so that we don't get disturbed. Okay, so we have an additional layer over here, isn't it? And what is that additional layer we're trying to look at? By gender. That's why this one is so complicated. The Gautam, somebody raised the hand. Gautam, do you want to ask something or say something?
No, sir. Good, sir.
Shall we continue? All right.
Yes, sir.
So now we've rejected the null hypothesis and we conclude that the response seen is better in the active treatment group than in the placebo group after adjusting for gender. I have looked at it separately for gender. I'll go back to this. That is by constructing this table. This one. You saw this? I have separated it out. I've separated it out and then I've analyzed it. I did not deliberately explain this complicated formula for you. Doesn't matter. We leave that and how to interpret this. So when you do the Mantel-Hansels test, we adjust for any additional variable that we want to keep in mind. So what is the conclusion of this new treatment now? Irrespective of gender, it works. It works in males, it works in females as well, is what we say. Okay. All right, so let's take now before you tell me, oh, this is urology, there's no urology example, and I'm a little bit lost. So this is an old paper, of course, Lancet 1996, something in renal transplant. This is a randomized controlled trial of steroid withdrawal in renal transplant receiving triple immunosuppression. So participants are those who got renal transplant and triple immunosuppression those days, cyclosporin, azathioprine, etc. 100 patients were randomized. Right now, we're reducing prednisolone treatment to 0 over 4 months versus maintaining just their triple immune suppression. Sorry, let's go back here. Okay, so results. These are the results. Okay, but more important than that is how do we write the chi-square test? So this is the statistical section in this article. This is an old Lancet thing. Okay, so difference in categoric data were assessed by the chi-square test along with AIDS correction. Okay, so 25 out of the 47 of the withdrawal group had greater than 25% rise in creatinine compared with 9 out of 50. So 25, roughly 25 out of 50. So roughly there were 100 patients or 93 patients, I think, 97 patients, sorry, 97 patients. Out of that, 25 out of 47 was in this group and 9 out of 50 were in that group. Okay, so this is how we write this. Chi-square is 11.7 and p less than 0.001. They should actually ideally also give the degrees of freedom. Okay, so there is something on the Mann-Whitney-U test. Okay, so I will leave that here because in a few minutes we are going to look at the Mann-Whitney-U test. So this is how it's written. As I kept telling you all multiple times, next time you read a journal article or read some thesis or somebody is presenting and they're saying statistics, these new people today you met Fisher and Exact and Mantle and McNemar and Mann-Whitney, all these new friends you made today. So the next time you meet them in the corridor, you can say hello to them. Yeah, I know you. I'm familiar with you. Okay, let's move on. Told you about the Mann-Whitney-U test. What's a Mann-Whitney-U test? Again, it's a non-parametric test. It's a non-parametric equivalent to the independent sample t-test. Okay, so assumptions are the dependent variables are ordinal and the independent variables are categoric. Now, the difference between dependent and independent variables I will do for you when we do correlation in the next 5 minutes. Okay, right? And yeah, let's continue on. Let's take an example. I have two analgesics, A and B, two types of analgesics, and I have 12 patients with rheumatoid arthritis. I'm going to randomly allocate 6 to each of the groups. It's a small sample size. I'm deliberately giving small numbers so that we can understand the calculations. Now, each patient rates the effectiveness of their analgesic, 0 being totally ineffective and 10 totally effective. Okay, 0, no effect at all, 10, perfect, pain totally disappeared. Okay, so here are our 6 patients with drug A and 6 patients with drug B. Each patient has rated, okay, 3 and 4 and 2 and 6 and so on. And here we rated also. So now if you look at it between drug A and drug B, remember the numbers are very small. Okay, and we can only do a median here. This will not be normally distributed. You will not do mean and standard deviation. So we do median 3.5, 7.5, almost double. Okay, almost or little more than double. 3.5 into 2 is 7. This is 7.5 now. Okay, big differences now. Okay, so but keep in mind, these are independent groups. A is a different group, B is a different group. They were randomized. This is not same patient before and after. There's another test for that. We'll come to that. Okay, so we have 3.5 and 7.5. Now, what you're going to do is you're going to rank all the ratings, ignoring the groups. So as always, I'm taking you behind the scenes to tell you how this works. So remember drug A, right? And this is drug B. Okay, so patient 1, 2, 3, 4, 5, 6, patient 1, 2, 3, 4, 5, 6. This is the rating. This is the actual rating that you saw on the previous slide. This is the actual rating. Now we are going to rank it, ignoring the groups. It doesn't, sorry, ignoring the groups. Okay, so which is the lowest ranked one, right? Number 2 is the lowest ranked. We happen to have one more number 2. Therefore, we give it a tied score of 1.5. Okay, there will not be 2 now because we already gave 2 numbers to 1.5. The next number will be 3. So after 2, we have 3 here. Then 4 gets 4. Okay, now the next number is 5. The rating is 5, but we seem to have 2 for 5, 5.5 and 5.5. You got how the rating was done? Now, since we have two 5.5s, we won't have 6. The next number will be 7. Now, we have 6 twice here. So it will be 7.5 and 7.5. Okay, that's why I took 6 and 6 so that we can kind of understand. So we have now ranked it, ignoring the groups. Now, interesting thing, we are going to total the ranks of A and we get T1. We're going to total, this is T1. You totaled all this ranks. If you want to go back for A, if you total all of this, okay, we got 23. And for B, we total all of this and we get 55. So the score for group A is 23, score for group B is 55. Right? So step 3 is you select the larger rank total and we call it TX. This is T1, this is T1, and this is T2. The larger of the two ranks is TX. So now this is clearly larger. So this is TX now. We call this TX. Okay. Then we have N1, N2, and NX. Why we need to do all this? There is a formula that's coming. Okay, N1 is the number of patients who took drug A, N2 is the number of patients who took drug B. Okay, NX is the total number of patients in TX. All right, I hope it's not too complicated. Very simple. If you followed me step by step without getting distracted and checking, no cricket score now. But if you were checking something else, then you would have lost track. If you're following me, this is very, very simple. Okay, so Mann-Whitney U test. So this is the U distribution. So we need to find U. The formula for U is here. Don't even bother. Okay, up to here, minus TX. So we get this. So 6 into 6 plus 6 into 7 by 2 minus 55. That's what we get. And U is 2. Okay. So step 6 is use the table of critical U values for Mann-Whitney U test. The obtained value for U is 2. Critical value is 5. Let's go. Let's look at this. Oh, okay. Oh, I don't have the table to show you. Okay. So what are we concluding now? That the two analgesics differed in the rated effectiveness. So that is how we make a conclusion. And of course, the software will give you the p-value, or if I go to the table and look at the degrees of freedom, you will get the p-value as well. Okay, the last test for us to look at in non-parametric is the Kruskal-Wallis test. Again, non-parametric test. Okay, an extension of the Mann-Whitney U test for what now? 3 or more groups. Can one of you tell us the parametric equivalent, 3 or more groups? It's ANOVA. Remember, it's identical to the one-way ANOVA, or it's the analogous to the one-way ANOVA. Apply to 3 or more groups, 3 or more independent variables. Let's take an example now. It's always good to look at a clinical example and take it from there. Okay, now I got a new drug for depression. Let's go to after rheumatoid arthritis and peptic ulcer and renal cells, etc. We'll go to for depression. Okay, different dosage regimens.
Dr. Chetan, you can mute yourself. Chetan, can you mute yourself?
Okay, I muted. Dr. Arvind, I will make I will make you co-host.
Okay.
So you can also help in muting people who are inadvertently leaving it open. Okay, so you will be able now. If you go to their thing, you will
Okay.
be able to mute
Yeah,
it as
sure,
well. Okay,
sure.
right. Thank you. Okay, so let's continue. Okay, so now I have two questions now. One is I have a new drug for depression, but I'm not sure which dose is right. If I give too much of a dose, the patient, is too depressed or too drowsy and cannot normally function, is not waking up in the morning, etc. But if I give smaller dose, the patient is still not waking up because the patient is depressed. Okay, what is the right dose is what we want to see. So different doses. Okay, so I have 24 patients now. I'm going to randomly allocate them into 3 groups, not 2 groups, into 3 groups. One is no drug, one is once a day drug, and the other one is twice a day drug. The same drug, once a day, twice a day, and no drug, or let's say placebo. Okay, then after 1 month, you ask the patients to rate their levels of depression on a scale from 1 to 100. Okay, 1 is totally miserable and 100 is the other extreme, ecstatically happy. Okay, so there we go. So we have now, how many we said? 24 patients. So we have 8 patients here, 8 patients here, no drug 8 patients, once a day drug 8 patients, and twice a day drug 8 patients. So mean score over here is 39.63. Here it is 40, and here it is 55. There seems to be some difference in the double dose compared to the single dose, and single dose compared to no dose. Although these two are very small difference, this is almost 40 and this is 41, 40 and 41. Okay, and again, look at the standard deviations for all this. It is fairly normally distributed. See, the standard deviation is less than 1/3 in most of the cases, right? And then therefore we can use the mean as well here. So how do we calculate Kruskal-Wallis? Again, we rank all the scores ignoring groups. Now it will be 3 groups now. That time we had only 2. Okay, we total all the ranks. So here we go. So we have no drug, once a day, and twice a day drug. Okay, so we are going to rank. So what we see in brackets is ranking. If we want to test it again, what is the smallest number I can see? 22, then 23. After 23 is 26. Then next one is 20. So you see 1, 2, 3, 4. After 27, where is 5? Where is 5? Okay, there is 29. 5.5. There must be another 5.5 somewhere. Here, 29. So this sum of ranks 76.5 is a total of this ranking here. Okay, and the 79.5 is whatever is in brackets over here. All right. Okay, we got that. And this is the formula now. So for Kruskal-Wallis, this is H. Do you want to even try and figure out this formula? Don't bother. Okay. So N is the total number of patients. And I calculate this H. And this H is 7.27. And the degrees of freedom is number of groups minus 1. Number of groups is 3 minus 1. Degrees of freedom is 2 now. In the previous situation, degrees of freedom was 1 for the 2/2 table. So this is degrees of freedom is 2 now. Okay, then we assess significance, and then we look at the critical value using the same chi-square test. And here we go. So degrees of freedom is 2. All right, and our P value of 0.05 for degrees of freedom for 2 degrees of freedom is 5.991. And what is and why do we look at this now? Our number, let's go back a little bit just to see what are the calculated number we got. Okay, is 7.27. 7.27 in this table lies between 0.05 and 0.025. Okay, so we can comfortably say it is less than 0.05. But of course, as I keep telling you, the software these days gives you the exact p-value. So this is statistically significant. You can even say highly statistically significant because it's much lesser than 0.05. All right. Okay, so that's how we write it. So we conclude here. What do we conclude here? We conclude that the likelihood of H or the Kruskal-Wallis being significant lies between 0.05 and 0.025. There a difference exists between the groups. Now we need to further inspect the group means or the medians to decide which is precisely low and how much they differ. You saw the difference between the three. We can do further tests to calculate that. Okay, with this, let us summarize chi-square tests. So chi-square test is a non-parametric test. I did not tell you the different types, goodness of fit, association, and homogeneity, right? It does not measure the strength of association. It only tells you there is an association, right? Strength of association is with an odds ratio. I told you this last time as well. Okay, not reliable for small sample size when expected value is less than 5. Therefore, we do the Fisher's exact test when the expected value is less than 5. And you can also calculate the exact p-value with that. That's why it's called the Fisher's exact test. McNemar's test is for matched data before and after. Okay, it's similar to the paired t-test, but this is the non-parametric version. And the Mantel-Hansel's chi-square test is to compare the probability of an event occurring in stratified samples. Remember the example of migraine and gender, and we found that it was effective irrespective of gender. Okay, it's an analog of the two-way ANOVA. Mann-Whitney U test is similar to the independent sample t-test. Right, these are the assumptions that we have. And finally, the Kruskal-Wallis test is a non-parametric test identical to a one-way ANOVA. All right, applied to 3 or more groups, and when there are more than 3 independent values, 3 or more independent values. All right, so that's what I wanted to share with you today. On the non-parametric test, we can shortly do the we can do correlation now in the next 20 odd minutes that we have. But I'll pause here for some time and 1 second, please. Okay, and I'll request Dr. Arvind to make some comments while I finish my cup of tea. Go ahead, Dr. Arvind, please.
So indeed, I was watching and listening to Dr. Dennis very intently. And what I understood, I'll just summarize. The last summary slide has actually brought out everything. But today we have discussed the non-parametric tests, and the chi-square test is the one that was very widely discussed. A few important points that I noticed is that Yates correction is something that is very important. Whenever the correction, the number of cells are less than 5. When there is a very low sample size, then we need to take help of the Fisher's exact test. We also need to know that which tests are an analog of which test. For example, he mentioned very nicely that the KW test, that is Kruskal-Wallis test, that is an analog of ANOVA test. So whenever you are dealing with a non-parametric data, it is the KW test that you are dealing with. I also understood the Mann-Whitney test is the U association, which actually brought out with a very nice example, and it is an analog of the T test. This is what I actually understood, and it was very nice if somebody is listening very intently to it. My one question to Dr. Dennis is that among all these non-parametric tests, nowadays all softwares are available. So what is the relevance of understanding all these tests whenever we are in the era of AI? Can we dictate to the AI that yes, now I find this data to be a non-parametric data with a sample size of which is very low. So please apply the Fisher exact test. So what is the relevance in 2025 with the onslaught of AI?
Oh, sorry, I was on mute. As you know, even to give instructions to AI, we need to know what we're talking about. Okay, and as I always kept saying, it's for us as medical people, we need to understand the principles, or what's happening behind the scenes a little bit, and then not just be overawed by what we are seeing. Of course, that formula and why something is squared, and why you divide this by that. Those are all PhD thesis. Each one formula they would have done one thesis, not for us. Okay, and for that we need in-depth understanding of mathematical computations, etc. However, for us, we need to understand, and again, and I will say this when I do the sample size, Dr. Arvind, is how do we talk to the statistician? So of course we don't tell the statistician do Kruskal-Wallis for this or that, but when they are telling, we at least know what is going behind. And to take the example or analogy of surgery, right? In year one you studied anatomy, the different layers, and the relationship between nerves and blood vessels, arteries, veins. If there's an artery, you're a little more careful. So we need to know what is happening there, so that we're able to understand. So as a start, it's good for us to know when or understand it as we are reading the papers. And of course, later on when we're doing it for our own, it's a little more enhanced understanding. So again, in the era of AI, why do we need to know it? I would say all the more reason for us to understand the concepts. Don't even bother about any formula or any computation. So what happens? So suppose we are doing before and after, what kind of data is this, and just for us to have a little broader understanding. Now, one common thing that people say is, oh, now I understood, but next week I can't remember anything. Okay, forget about next month, next week. And it happens. I've taught this so many times, but before every class I will sit and revise this again, how this, okay, because we don't do this on a daily basis, although I teach this quite often. All right, Dr. Arvind, so shall we do correlation alone in the next 15-20 minutes or so?
Yes.
And then in the next session, let's do regression. So let me pull out my slides. Okay, this is correlation. Okay, so although the session says correlation and regression, we'll do correlation today. Regression is a fairly vast thing which we can do next time. Okay, so what are we doing in correlation? Trying to understand variables. Remember a moment ago I told you we'll figure out what is dependent and independent variable. We'll do that now. Types of variables, types of correlation, what is the correlation coefficient? You will do it often. In fact, I have a nice example on PSA, prostate specific antigen, and then how it relates, how it correlates. Okay, how do we compute the confidence interval here and then figure out whether it is statistically significant or not? And we are not doing regression today. All of this is for next time. So I'm sure you've heard multiple linear regression, multiple logistic regression, and they use it so often in our in our research. But today we will stick to correlation. Okay, what is correlation? I want to understand the relationship between two quantitative variables. How are they related? Okay, so we do correlation. So we can also do linear regression for that. Okay, now correlation gives us the strength of relationship. Chi-square test, there was no strength of relationship, right? Was it associated or not? Okay, but here we can actually look at the strength of relationship. Regression, we put it in the form of an equation and we can explain further and we can predict. We can predict outcomes. That is really fascinating. But today we'll not go into that. Today we'll only look at this. Variables. What we observe or measure in an experiment is called variable. Anything that varies is called a variable. Okay, and that is on the x-axis. X-axis is sleeping axis, lying down. Sometimes we get confused, right? Which is x-axis? So standing is y, sleeping is x. Okay, right. So that is the variable being changed, right? It could be increasing dose of drug, or over a period of time, whatever it is. Okay, that is in the x-axis. Okay, like a dose of a drug. Okay, it can also be a variable which cannot be changed, such as current age or gender. Now, the dependent variable is in the y-axis. X-axis lying down, totally independent, relaxed. Okay, but the dependent variable is standing up. Look at it like that. Okay, we always get confused with this, or not always, many times we get confused with this. So I put something into my head for me to remember as well. So that is the outcome of interest. I'm changing the dose of the drug. What happens to tumor size? What happens to blood pressure? What happens to blood sugar, etc.? It's the outcome of interest, and it is that something that changes in response to some intervention. I gave you the example: blood pressure after antihypertensive medication, or also, number of people who are alive or dead, or recurrence of cancer or MI or stroke. Those are all on the y-axis. Okay, let's take a real example now. Relationship between age and urea levels, serum urea levels. Now, it so happens that some data are not normally distributed. So what we do is we have to log transform it. I'm also showing you data transformation briefly now. So sometimes when you get log transform data, you're wondering, what is this? Why did they do that? So when it is not normally distributed, one of the options is to transform it so that you get normal distribution, and you do the analysis. And then you remember from school, from high school, you do log, and then you go to another table and look for anti-log, right? You get it back. So taking you back to school mathematics. Okay, so you will represent it on a scatter diagram. So let's take now data of 20 people, participants 1 to 10 and 11 to 20. And what is in the second column is age, and this is urea. This is log normal urea, or log transformed urea, or log normal urea. Okay, just eyeball the data. I deliberately gave you only 20, not 200 or not even 80, 90, just 20. What is happening with age? How do you look at that? Look at the lowest age and the highest age. Let me see, which is the lowest age here? 45. Anything in the 30s? Okay, we have 37 here. Do we have anything lower than 37? Okay, 37 here is 1.4. And which is the oldest? 89 here. 89 is 2.2. 81 is 2.05. 84 is 1.9. This is biology. Okay.
91.
Uh,
90,
we have
91
91
is
as,
there.
we have 91 as well. 91 is 2.7. Now what, Satya, what I was trying to say is 81, let's say 89 is 2.2, but 84 is 1.9.
Okay, sir.
Got it? All right.
Yes.
So anyway, this is what it is. And if I put that in a scatter diagram, this is what it is. So as age increases, urea is increasing. Okay, right? But again, look at biology. This person's age is 60, but urea is 1.1 or something. This person's age is 50, but here it is 1.6 or 1.7 something. You saw it? So that is how biology is. Okay, so correlation. It is a statistical technique to determine the degree to which two variables, how much are these two variables related? I am going to now quantify the relationship. Assumptions, these are independent. Both variables are random. Variables are normally distributed. Now that happened to be not normally distributed. So now I have log transformed it. Okay. And then we take a scatter plot. Independent and dependent variables, I already told you. You're not going to join the points, but you're going to now find the best fit line. But before that, let's look at the types of correlation. Now, let's look at some other data. Okay, this is one. What is happening here? This, as X increases, Y is also increasing. This is a positive relationship, and the way we quantify the relationship is with the correlation coefficient small r. This is 0.9. Now, what is this? As something is increasing, X is decreasing. This is increasing, this is decreasing, and this is a negative linear relationship of 0.9. Okay, negative relationship of 0.9. Now, what about this? There's no linear relationship. Nothing. It's almost like this. All right. Now look at the next one. What is this? This is a non-linear, no linear relationship versus a non-linear relationship. Okay. Something increases like this and then it decreases. Can you think of an example in biology? Something goes up and down. Muscle strength. Let's take an example of muscle strength. Let us take this age as 18 here. Okay. Or age and this can be muscle strength or even height. As age increases, height keeps on increasing. And what can you think of something decreasing? The more we spend, the bank balance keeps decreasing. Okay, maybe. Okay. And here there is no relationship. Here, suppose this age is, let us say 45. This is 45 and this is 65. Or let's say 85. Okay. Some of us are approaching 60. So we'll push a little further away, 85. Okay. So up to 45, muscle strength keeps on increasing. Afterwards, it keeps on decreasing. Okay. And maybe memory power as well. So something like this, memory power. Hopefully it doesn't. That's why I stopped here. It is not coming to 0. Okay. All right. So these are the types of relationship and some examples from biology. Now, thing is, how do we calculate this is the question. Okay. Right. When not use correlation is when you have outliers like this. This will really skew it. Okay. Or when there are two subgroups, one over here and one over here. Correlation is not recommended in these two situations. These are the things that statisticians will tell you. No, I want to do this. No. Then they'll say, no, I looked at it in a scatter plot. See, for them, they literally have a manual in their mind. If something has to be done, this has to be fulfilled, this, and they remember it in their head. So they will do a scatter plot, they'll do some other tests, and then they'll tell, no, we can't do correlation, we have to do something else. The distribution is like this, like that, they will tell you. Okay. So yeah, so that is this is why importance of a scatter plot. I think I told you session before last that every time we have to look at the data and look at it visually as well for us to understand the data before we are able to do any tests. Okay, calculating the correlation coefficient, the degree of association. Okay, one is called the Pearson's correlation coefficient for parametric data. The full name. Okay, the other name, the other one for non-parametric before that, sorry. For non-parametric, it's the Spearman's rank correlation coefficient. Okay, denoted by R. Both are R. Okay, so Pearson's full name is, Pearson's test full name is Pearson's product moment correlation coefficient. And so this is the equation. Okay, Satya, please by heart this equation. It will come for your urology exam. Okay.
Yes, sir.
Okay. Okay, you're still listening, so he's smiling. Okay, don't bother. Okay, so in this, what do we have? Xi is the independent variable, yi is the dependent variable, x bar is the mean of the x values, and y bar is the mean of the y values. Okay, so when we computed this R, I got it based on the formula. I got R equals 0.62. Where is that? We are talking about urea, age and log normal urea. When I put that 20 people's data here, the independent variables, each of them, okay, X bar and all of this. So whatever is needed here is available in that table. And I got R equals 0.62. What is this 0.62 is what we as doctors must understand. Okay, not that formula. Here we go. So firstly, we look at the difference between Pearson's and Spearman's rank. Pearson's was for normally distributed data. Spearman's, not normally distributed data, we can use it. Okay, this is a parametric test. The full name, as I told you, is a linear product moment correlation, or this is Spearman's rank order correlation. That's a full name. Even journals don't put the full name. They'll just say Spearman's or Pearson's correlation. More important for us is how do I interpret the R value? R value -1. When you get 1, it's a perfect correlation. -1 is a perfect negative. +1 is a perfect positive linear relationship. 0 means no linear relationship. Okay, this is important. 0 to 0.25 plus, when we don't put a sign, it is +0.25 or -2.5. Okay, it is little or no relationship. 0 to 25, no relationship, little or no. 0.25 to 0.50, some relationship, fair relationship. 0.5 to 0.75 is moderate relationship. Okay, anything more than 0.75 is a good relationship. Okay, or a strong relationship. So closer it comes to 1, +1 or -1, it's a strong relationship. That's it. Okay, so so this is the okay, how do we test this? And in the good old days, how did we get the p-value? Okay, let me explain this here using this table. Okay, so this is the probabilities. This is for sample size for correlation. Okay, and don't worry about two-tailed probabilities. Well, two-tailed probability simply means it can go either way. With age, urea can increase or decrease. At the time, we did not know. So what is our sample size? Our sample size is 20, correct? Right? And what is the answer we got? Sample size 20, R is 0.62. Okay, so R is 0.62. 0.62 is even beyond 0.56. So this is p-value less than 0.01. Got it? As simple as that. In the good old days, people looked at these tables, but now the computer will give it to you. So as I kept telling you, I'm going behind the scenes to show you how it is done. Okay, right. So our value of 0.62 for a 20 sample, right, is greater than 0.56. Here is 0.56. It's greater than 0.56. Hence, P is less than 0.01. This is 0.01. Okay, so what are we telling? There is a moderate relationship. More than 0.75 is a strong relationship. There's a moderate relationship. Even this moderate relationship is statistically significant, is what our conclusion is. So there exists a linear relationship between age and log normal urea is the conclusion we make. All right. So do we need to go here as well? I think we'll skip this part. Okay. I was just trying to tell you, how do we calculate the 95% confidence interval? Remember, we did the Z value, all right? And then 1.96 for 0.05. This is the standard error. If you do that, so we get the confidence interval 0.25 to 1.99. Okay. So now we need to inverse. Remember, it was transformed. We have to inverse transform it. When I inverse transform it, for the 95% confidence interval, I get 0.62 and 0.25 to 0.83. So this is how we write the confidence interval. Remember, I told you, when confidence interval remains on the same side, it is statistically significant. So 0.83 is much lesser than 1. Okay, it's quite a bit far away from 1. So this is statistically significant. So that's another way of looking at it. And these are all the formulas you compute. This is the standard error formula, and all of that we compute it and we get it. Okay, let's conclude with an example from a 2010 paper in urology. This is correlation between serum, PSA, and cancer volume in prostate glands of different sizes. What all we have now? We have PSA, we have cancer volume in the prostate gland, and different sizes of the prostate gland itself, all three. All right. So let's look at it now. Okay, those are the objectives. So 1,234 men with data on prostate weight and tumor volume. And of course, we also have PSA. Now, prostate size was classified into tertiles. Tertiles means 3 categories or 3 groups. Small is less than 41.2. Medium prostate size is 41.3 to 54.5, and large is greater than this. You may or may not agree with this classification. I'm not sure it is a standard one. That doesn't matter. And then we have different PSA levels. Okay, so they are doing Pearson's correlation coefficient to examine the relationship of PSA with prostate size and tumor volume. Okay, so now all this makes sense now, isn't it? So this is what I'm going to look at. Okay, so this is the characteristics. What is our number of patients we have? Oh, this is a very good number. Oh, interesting. 1, 2, 3, 4 men. 1,234 men. 1, 2, 3, 4. Okay, median age 59. Preoperative PSA is 4.9. clinical staging, T1, T2, Gleason score, pathological features, etc., etc. This is surgical margin, seminal vesicle invasion, and metastasis. All of these characteristics are there. That's usually table 1. You get the characteristics. Okay. So this is now our scatter plot. Okay, this is preoperative PSA, right? You see one thing clustering around here and then a few more here, nanograms per ml, and here is our R square, 0.0109. Okay, right? So that is why the slope of this line is like this. When I do regression, I'll tell you more about slope. If it was something like this one would have been 0.82 or something. Okay, right. Now this is preoperative PSA. Oh, this is versus prostate weight. This is prostate weight and this is PSA. And here this is tumor volume. Do you see the slope of this line? Little more or little more acute here. So R squared is 0.13. There's no 0, 0.13. And this is what we saw. This is tumor volume to preoperative PSA. Okay, so let's look at the results here. This is the correlation between preoperative PSA level with prostate volume and tumor volume. So this is the preoperative PSA. Okay, these are the number of patients. So 1200. So for some reason in this 3 tertiles, somewhat equally, it is 411. Mean prostate weight 35, 48, 73. Okay, this one is 0, 0.09 and 0.11. So at mean prostate weight of 73, right, p-value is significant. Okay, next, this is preoperative PSA and mean tumor volume in centimeter square. This is in weight. This is tumor volume as measured. I'm sure this is a highly sensitive thing to measure. Number of patients, the same thing. Mean preoperative, these two data are the same. Here's tumor volume, 4.7, 5.7, and 6.2. Okay, right? All three are correlated and all three are highly statistically significant. So if you want to now take a clinical decision, which one is more reliable? Clearly, it's the tumor volume. You will say, no big deal, I know that well, but this is, tumor volume was more strongly correlated. So conclusion is PSA was significantly correlated with prostate size only in the largest prostate glands here, only here. Okay, but was significantly associated with tumor volumes in small, medium, or large prostate. That PSA continues to be a better marker for tumor volume than for prostate size. Okay, so that's what was done about 15 years ago and published, and I'm sure data has advanced in this. Okay, so that is the end of correlation. I took a little more time, but let me tell you what's coming next week. So we will look at what is regression, how do we apply regression, simple linear regression, multiple, and then we look at how to predict HbA1c, what are these variables. We look at BMI and diabetes control. We look at simple logistic regression, multiple logistic regression as well. All right, and also a little bit on sample size for regression. And let me show you, slide sorter view. Give me a few seconds. Oops. Okay. All right. Let me share this again. And I will conclude in the next 1 minute. Okay. So you can see my slide sorter view. So this is the outline. So we look at, what do we use regression for, the types of regression, assumptions in regression. We'll understand the regression line and some of the slides with some heavy formula I've hidden, as you can see, but I'll explain to you here some of them. So this is simple regression. Then we look at multiple regression. How do we calculate that? A little bit of formula are there now. Don't get, as always, I'll tell you the concepts behind this. We look at the examples again, and we'll do stepwise regression and logistic regression as well. And then do we have an example? Okay, I have my own paper. I will show that to you. And then we'll kind of summarize. And if you see here, this last summary slide, please don't miss next time's session. This last summary slide will give you a nice idea as to when data are continuous or dichotomous. Linear regression, When do we use simple linear regression? When do we use multiple linear regression? Then finally, logistic regression. When do we use simple? When do we use multiple logistic regression? So that was conclusion of correlation, and I gave you a preview of regression for next time. Dr. Arvind, over to you.
Yes, thank you very much, Dr. Dennis. Complicated things made very simple. Thank you so much for sparing your time and making us understand such a complex topic. Today we discussed the non-parametric tests as well as something about correlation, the Spearman's rank test and the Pearson's correlation coefficient. So we look forward to hear something about the regression analysis next time. Thank you again, Dr. Dennis, for this talk. See you.
Thank you, Dr. Arvind. Very kind of you to summarize and to give us, your comments. So we'll close with this and then we'll catch up next week. Okay.